This was a case of an endophthalmitis due to the Bleb infection. First I took a dry sample of the vitreous and then I removed the fibrin into the anterior chamber and cleaned the anterior chamber. I thought that the case was pseudo-phakic, but the patient was phakic, and I decided to preserve the lens. So after the debridement of the corneal epithelium, I performed vitrectomy always inducing a PVD to detach the posterior highlight from the macular area, and then a complete or peripheral vitreous saving to remove as much infected tissue as possible. Then I removed the infected Bleb, and then I had this leak because of the limbal tissue was necrotic, so I decided to completely remove this tissue and close the gap. I could have covered it with some scleral patch, but since the gap was small, I finally sutured it. Then I performed fluid exchange and silicone oil into the vitreous cavity, leaving also intravitreal antibiotics. And finally, I advanced the conjunctiva to close the necrotic limbus and wait for 3 months. Fortunately, the patient did quite well, and after 2 months, I performed the surgery with phacoVitrectomy. The case was complex because of the synechia, the shallow anterior chamber, hard lens, and silicone oil into the vitreous cavity, and also the tonora was weak. As you can see, when I performed in the capsulorhexis, the lens was moving a lot, and also during the phaco, the lens was moving a lot because of the cannula damage because of the infection. So I performed the phaco with the stomach and choke technique, and when I removed the lens, as you can see now, it was quite mobile. The bag was moving with the lens, and I had to be very gentle. But when I finally removed the instruments and especially the IA, due to the pressing of the silicone oil into the vitreous cavity, all the capsular bag moved forward, and I could observe the tonular dialysis in the temporal side. As you can see now, I'm removing the less remnants, and I want to take up the phaco. You see the tonular dialysis. So I kept on removing the cortical material, moving away from the tonular dialysis, and as you can see now, it was quite easy to engage the capsular bag and generate traction over it. So I decided to inject viscoelastic prior to taking out the IA, and then I implanted a capsular tension ring and the intraocular lens. And I did all of the surgery with the silicone oil into the vitreous cavity because I prefer to have the support of the silicone oil in the vitreous. And then I'm suturing the anterior chamber, removing the silicone oil, and after the removal of the silicone oil, I cleaned manually the viscoelastic into the anterior chamber. It is important to do this manually to avoid the decompression of the anterior chamber and the enlargement of the tonular dialysis. So I finally removed the viscoelastic and then injected some myocol into the anterior chamber and replaced the lens into the 3-9 position. And now I'm doing the fluid exchange, air fluid exchange for 3 times to remove the debris of the silicone oil. And finally, in this case, I'm leaving BSS, and I'm also removing the anterior highlight that was filled of debris of the infection. So finally the case went well and the patient could recover the visual acuity, but it could have been prevented removing this necrotic tissue of the Bleb.